Quality assurance. We're very excited to tell you about a special promotion for select callers. This will only take a moment. By answering just a few questions, we will find out if this offer is right for you.
Okay, do we have,
Years of age or older.
hang on a second.
Again,
We've got
60 years of age or older.
maybe a second here. All right. So,
Are you or someone in your house? Just for calling today, you are qualified.
all right. So Jamie's going to check to see who that line is that we're getting a little bit of background. But my name is Jill Hansen. I am one of the improvement advisors here at the Wisconsin Hospital Association, and I wanted to welcome all of you today to the Emergency Department Transfer Communication Improvement Collaborative. This is our first webinar of a three-part webinar series, and today's focus is really going to be understanding the measures and the metrics, as well as identifying those gaps in practice. So again, I will be the lead for the EDTC collaborative for all of you. We also have a subject matter expert who is Robin Carlson with Stratus Health. We actually have a mentor hospital, Sue Kautz, with our Mercy Hospital Medical Center in Walworth. She'll also be part of our webinar as well as our coach calls. And then I wanted to share with all of you the hospitals that are actually participating in this collaborative. So we have, I'm going to say each hospital name, and then if you can chime in if someone is on the line. I don't need all of you to chime in. If you're multiple people from that organization, but I just want to make sure that I have captured the attendance because I will be tracking attendance for both the webinar as well as our coach calls. So do we have anyone from Mayo Clinic, Chippewa Valley, and Bloomer?
Enter Northeast side, followed by pound.
All right, and I am looking, do we have representation from Osceola Medical Center? All right, and I know we have representatives for both SSM Health Ripon and SSM Waupun on the line. Do we have anyone from Theta Care Wapaka?
Yes, this is Jareen Madigan and Audrey Rosine, and Maggie is joining us shortly.
Okay, all right, perfect. Thanks, Jareen. And then do we have anyone from Theta Care Shawano on the line?
Yes, Jason Brooker, I'm here.
Okay, thanks, Jason. All right, so we are getting a little bit of background noise. I would just want to remind you that if you are dialing in, could you check your, I'm drawing a blank here, your speaker on your computer and turn the speaker volume off on your computer. Okay, that seems to have fixed that piece of it. So today's agenda is actually brought to you, so we're able to provide this webinar today with funding from the Wisconsin Office of Rural Health, so we're really appreciative for that Flex Grant opportunities. We're actually looking at the Medicare Beneficiary Quality Improvement Project, or the MBQIP, EDTC specific measures. And initially when I had put out the invitation for your organizations to participate in this collaborative, the initial focus based on sort of our initial data was around that EDTC measures 2, 4, 5, and 6. When we actually reviewed your responses from your gap surveys that you had completed, we identified additional measures. So this three-part webinar series and the coaching calls is really going to focus on those topic areas that you identified based on your gap. So we identified the metric and the components for the administrative communication, the metric and components for vital signs, medication information, physician or practitioner information, and then the nurse-generated information. So as I mentioned, we have a three-part webinar series, and there's a subsequent slide where I kind of walk through, here are the webinar dates and the coach call dates. All of you should have received an Outlook invitation, and then as we prepare, so as the March webinar comes up, you will see the PowerPoint presentation slide be added to that Outlook invitation. That way you have all of the materials with you right when you're ready to call in for that as well. We are also asking the participant hospitals to actually be part of those coach calls. So we're fortunate enough to have Sue Kautz from Mercy Health in Walworth, is actually going to be our mentor hospital. So while we have Robin Carlson participating as our subject matter expert, and she's available on our 3-part webinars, Sue is actually going to be a part of both webinars and our coach calls. And so those will be an opportunity for you to actually kind of bounce ideas off of each other as well as ideas off of Sue in case you're kind of getting stuck in any part of this process. With this webinar, along with each of the subsequent webinars, we're actually going to look at that data, so you'll see that data get populated. We're fortunate enough with this project, you already provide this data over to the Wisconsin Office of Rural Health, so there really isn't, from a data submission piece, that piece is already taken care of for you. So really your part for this is really to participate in the webinars and the coach calls and really identify kind of the areas that you want to focus on. And then we're going to kind of wrap up today's session based on sort of your gap summary. We talked a little bit about, do you want to have a better understanding of sort of that action planning as well as small tests of change? So today, our initial focus is really going to be starting with the Plan, Do, Study, Act. And I think it really kind of, once Robin gets to sort of drilling down to the metrics components, it's really going to be able to help you better identify not just about that specific metric, say administrative communication, what component of that metric specifically do you want to focus and do you want to do a small test of change? And then really we'll use that information then as we go forward for the subsequent webinars. So just a reminder for all of you, you may or may not be as familiar with the available resources, but I just wanted to call out to all of you the available resources through the Wisconsin Office of Rural Health. Actually, I kind of did a screenshot of that landing page. You're going to see on that very bottom corner of the page itself, they actually have specific fact sheets for each of the metrics that you can utilize. And then on this page as well, you'll have a hyperlink to those specific measures and that website specifically. Knowing that these collaborative resources are also available on that ruralcenter.org. So I wanted to provide you that with you as well. And knowing that most of you are familiar with the MB-QIP measures and really sort of the components that all of you are abstracting data and putting in data for those measures really around sort of those 4 sort of pillars around patient safety and inpatient. Then we talk about patient engagement as well as outpatient. And you're going to see that emergency department transfer communication measures all fall under that care transitions component. What's really nice is that we're able to partner with Stratus Health for this collaborative because they actually have a really nice quality improvement toolkit specific to this project. And so their overall toolkit actually is broken down into various sections. So section 1 actually provides you with recommendations and principles for the care transitions from that emergency department. Section 2 gets at that piece that we talked about, really about small tests of change and how do you create those action plans and why they're so important for this work, especially as you move forward and really to identify what you want to work on. Section 3 actually provides you with sample checklists. I know a lot of you are working on improving the transfer forms and looking at identifying what's the best way we can track all of this information. That section of that toolkit specifically has that. There's additional resources as well. I would encourage you, if you haven't done so already, to actually go out to the website and pull down this resource and actually have that at the ready for your team. The other component that we talk about, and I think this really speaks to the feedback that all of you had given us specific to the measures with that kind of that gap assessment, but the data specifications manual. So I think there still is the opportunity to kind of walk through all of these because it really allows you to really see kind of what should we be collecting, how should we be collecting this. So at this time, I'm actually going to ask Robin to actually, I'm going to stop sharing my screen. I'm actually going to ask Robin to share her screen, Robin Carlson at Stratus Health. She's going to share her screen, which then she will walk through the metrics and we'll sort of touch on the various questions that you had kind of filling out that gap assessment. So as we're going, I would welcome you to feel free, as Robin kind of goes through the metrics, feel free to ask those questions. So Robin, I stopped sharing my screen if you want to go ahead and click share screen.
Okay, I think I did that. Are you seeing the specs manual?
Not yet. I'm seeing your name. So there, remember, there's a two-part step to that. So you have to say share screen, and then yes, I want to share my screen. It's click share, and then you have to click share again.
Okay, how about
All right.
there? Okay,
Yes.
sorry.
Yep. Nope, that's okay.
Okay, hi everyone, and Jill, thanks for inviting me today. What I want to do is go through, and I know that some of you may have been on a webinar that I did before, but, and I think it was about the emergency department transfer communication, but because of turnover and because I'll be the first to admit that maybe some of the instructions aren't as clear as they could be, and there's maybe some gray areas. I want to go through and talk about how I refer to them as the data elements. It's like, you know, you guys a lot of times when you're talking about, you talk about the roll-up measure. You know, like there's EDTC 1 and 2, but I want to talk about the data elements in those measures, because it might not be that you're getting, you know, that there's a problem with all of those in there. Maybe it's just one or two certain things that aren't documented. So I want to talk about things at that data element level. I'm pretty like casual, and so if you've got a question, just stop me if you don't understand something, if you think it's something different than what you heard in the past, or any kind of questions. I think it's easier maybe if we talk about them right as I'm talking about them. So that would be, you know, that works for me just fine. I'm going to go through, we brought up the manual, and I'm going to scroll through some of these first pages because I just, again, I want to hit the things where I notice that there's the most discrepancies. So sorry for scrolling, but okay, and this is the first part where I note that people always have some difficulty. And this is around the population of knowing which records, which of your ED visits should be abstracted for this, for the EDTC measures. So right here, okay, these are the list of patients that should be included. So patients who are seen in your ED and then transferred or discharged. We kind of use both of those words there because people kind of use them interchangeably. But patients who are seen in your ED and then discharged or transferred to a hospice healthcare facility, an acute care facility, and we got these terms from the CMS specifications manuals. So if any of you are familiar and also do some of the measure abstraction for inpatient or outpatient, these values come from the CMS manual. So really the numbers were the numbers that are from the CMS manual. So if they don't fit with your the numbers that maybe your billing uses for discharge codes, don't pay any attention to that. It's really the narrative that matters here. So patients who go to any hospice healthcare facility, patients who are discharged or transferred to any acute care facility, be it a PPS hospital, another critical access hospital, if they go to a cancer hospital or a children's hospital, a veterans hospital, any transfer to another acute care facility, and that would include the emergency department. Because at the time you're transferring, maybe they're going to, you know, initially start up in the emergency department, but any transfer to any acute care facility. Then you have other healthcare facility, and this is the one that tends to cause the most problems. Remember, it does not really matter where that person came from. It matters where they're discharged or transferred to. So if they're going, they're transferred to an extended care facility, a long-term care facility, a nursing home, a VA nursing home, a psych hospital or a psych unit of a hospital, a rehab facility, or a rehab unit of a hospital. If they're going to a skilled nursing facility or a swing bed, these are all included in other healthcare facilities, and they should be abstracted. Now, the big thing that we see where people are getting wrong is, according to the way a lot of billing is set up, if a person is seen, if a person lives in a nursing home and then they come to the ED and then they go back to the nursing home, it appears that a lot of billing systems consider that to be their transferred home. I'm not saying that's wrong. I'm saying that for this abstraction, that patient is being transferred or discharged to a skilled nursing facility, and that fits under other healthcare facilities, so they should be included. So make sure that you are abstracting those patients, because let me tell you, your values, your results from measures can look a lot different if you're not including some of these facilities, and that is incorrect. At this time, we've gotten a lot of feedback about this, and this is one of the areas that we're looking into seeing if we can possibly change. But for right now, ED patients that have been put in observation status and then are transferred to another hospital or healthcare facility should be included. And let me just say that none of this applies to patients who are seen in your ED and then directly admitted. These are patients seen in your facility and admitted to other acute care facilities or any other facility. Because we did find some people who were doing these on patients who were seen in their ED and then admitted to their acute care facility, and that wouldn't be correct. If they're seen in your facility but admitted to like a rehab unit or a psych unit in your facility or a swing bed in your facility, that's a different level of care. They're in a different spot, so that's something different, and they would be included there. So patients that are excluded, home for this purpose would be assisted living, if they went to jail or prison, if documentation would show like a board and care, a homeless shelter. Any of these other ones, they would be excluded. Any questions on that? Okay. I want to mention again about sample size, because we've had some differencing, people have heard different things about this. The minimum is 45 cases for a quarter. Now you might have less. If you have 20, you would do, all of them, but the minimum is 45. You can do all of them if you like. It's always been that way. If you have 100 cases, you can do all 100. If you have 300, you can do all of them. But the minimum is 45 for the quarter. We've got this little graph. Again, if you do CMS abstraction, this grid would look familiar because this is how the sampling is set up for CMS. But again, if you have less than or 45, you do all of the cases. If you have between 45 and however many, we want 45 for the quarter or 15 a month. And it is a random sample. Okay, it's come to my attention since I've been doing a lot more speaking with people across the country that some people are just pulling the first 15 transfers for a month. And that would not be correct, because that would not be random. I mean, you could potentially get all of that in one day, and that would be like your same ED staff. So you're not getting, it needs to be a representation of how things are done between, with all of your staff in that, in your department. So random sample, minimum of 45. Any questions around any of that? Okay, I will just keep going. Now, these next pages talk about the measures, the measure sets. But again, I want to talk about the individual data elements, so we're going to go there. First one, and I think the only one, if I look at the information that Jill sent, maybe the ones we don't have to talk about are the procedures and tests. But again, you guys stop me if there's anything that you don't think I'm going over or that you want me to discuss in more detail. But this data element is healthcare facility to healthcare facility, okay? If you're a long-time abstractor, you know this used to be called nurse-to-nurse communication, but we found out from you guys, we got feedback that it isn't always nurses doing the communication. Oftentimes a nurse won't be able to make any contact until after the patient has left because they're too busy taking care of the patient. Totally understandable. So we changed this to better, so there'd be a better understanding of what's really being looked for here. This does have to occur prior to the discharge of the patient, but it can be any ED staff in your facility talking to ED staff from ED staff from the receiving facility, okay? A big misunderstanding is the thought that it has to be a full report. It does not, okay? It can just be communication, checking to make sure that the hospital that you want to transfer to or the facility you want to transfer to has appropriate bed and services for the patient, okay? It doesn't have to be the report on the patient's condition. So I think a lot of times people are maybe missing this one because they think it has to be more than what it is. Okay, for all of these, the suggested data source is your emergency department record and every piece of data in that emergency department record. Notes for abstraction just say the date and time of contact can be used to verify that communication occurred prior to the transfer. So the big thing here is, again, this communication happened prior to the patient leaving your facility, but it doesn't have to be a full report. Physician-to-physician communication, again, this has to be prior to the patient leaving. A lot of times this information, well, I say that, but it depends. Everybody's EMTALA form is a little bit different, but most times this will maybe be on the EMTALA form. And let me say, you guys, none of this is really saying where, there's no certain spot in your ED record that this information has to be, okay? This is all about documentation in that ED record to show that these data elements were sent to the facility that you're sending the patient to, okay? It doesn't matter if it's on a nursing form, if it's on, you know, the ER note, if it's on a transfer form, if it's on the EMTALA form, if you made a transfer sheet with this information, okay? That's all fine. There isn't one site or one spot that this has to be. And I think maybe the best way, and I don't mean to be rambling, but as I think of these things, I want to get them across to you. I think the best way to think about this is think about if I was coming in to abstract this record, okay? And I don't know anything about your process. I don't know what you always do. If I looked at your ED record, would I be able to answer these questions with a yes? Okay, because that's what it's about. It's not about your process. Well, I mean, it is, but this is all about what's documented in your record about these things being sent, these data elements. Okay, so you're looking at that there was physician-to-physician communication, okay? This must include the name of the two communicating providers. We often see that maybe you won't have a specific name of the provider. Maybe you'll have talked to the cardiologist. I would let that go. If I had information that my physician, you know, or my ED physician talked to the cardiologist at the other facility, that's communication to me. Again, the big thing is that it occurred prior to transfer. You want to use the date and time of that contact to figure that out. And again, here, there's nothing that says what this conversation has to include. I mean, I'm sure they're talking a little bit about, you know, well, this is what's wrong with my patient. Hey, what do you think? Can you take them there? Whatever. But there's nothing here that says they have to say this or that or the other thing. Okay? It's more about times and that there was communication between the providers. Anybody have any questions on those? Okay, I think these next data elements, there's not question about what they are. it might be more around knowing that you have the NA option if it wasn't available. And by that I mean, here we say, if you've got a patient with a head injury or some kind of, they had a stroke or whatever and can't answer your question, you can't get their name, that's an NA. If the patient refuses to give it to you, that would be an NA. So you want to know, you want to see in your documentation that this information was sent to the receiving facility. Now, if you've got some kind of a sheet that says, well, I don't know, this might be kind of old school, but when we used to call them paper, the face sheets that had, the name and all the demographic stuff and the insurance. If I was reading a record and it said, a face sheet was sent with the patient, well, then I'd go look at that face sheet and see if this information is on there. If it is, well, then I'd be saying yes. So then you have address. I mean, that's same thing goes there. If the patient can't give you that information, then you can say NA. Oh, I should jump back for a second. Sorry. The physician-to-physician communication, that data element is only required if the patient is going to an acute care facility. Oh, excuse me for scrolling, guys. But I don't know which tool that you use for abstraction. I know on the Stratus Health Excel tool that question will gray out if you indicate the person isn't going to an acute care facility. So again, if you're sending a patient to a nursing home, you can put an NA because that's not an acute care facility. So anything that sits in that other healthcare facility, because it's pretty much a given that those facilities may not have a physician there to be receiving that information. So you could an NA if it's to a non-acute healthcare facility.
Robin, this is Jarena Wapaka. I have a question on that then. So would that include a psych facility?
Yes, because
they are.
I'm
okay.
Sorry. Yes,
no,
because
go ahead.
that is. Yes, I would say yes because that is under other healthcare facility. Okay. Okay, so patient name, address. Oh, sorry, I might be scrolling too fast. Stop me if there's any one of these that you think, again, this is all pretty much the basic demographics, age, date of birth, that is perfectly great for age. Gender, okay. Patient contact information. One thing that just came up around this that I hadn't heard of before, I've heard that a couple places have told me that a lot of times if they get a patient who's maybe coming from a nursing home or coming from maybe some kind of mental health facility, their contact information is just the number of that facility, okay, or and that really would not be acceptable unless, again, that patient, again, we say there's an NA if the patient is, has a neurologic problem, can't give you the information, but just the number of that nursing home that the patient went to, that's not really contact information. We're talking about family member, significant other, or friend. Now, it would be one thing if the patient didn't have any, how sometimes, people in a nursing home, maybe they don't have any, maybe there's a guarantor or someone who is their executor or something, but just the name of the nursing home itself, that's not really a contact. Insurance information, same thing. We should have insurance number or the name and, the policy number. If the patient doesn't have insurance, yes?
This is Jarena Wapaka again. So oftentimes, especially for a trauma patient coming in that's going to get transferred to a higher level of care, you might not have any opportunity to get that insurance information. with that, insurance is kind of one of those, you really can't ask them about insurance when they walk in the door in an emergency room. So when you're transferring them out.
I would say, you know, again, I wish some of these weren't so gray. They were more black and white. I would say if you've got a situation where neurologically altered, but that might not be in every trauma. Well, I almost want to say this one kind of has to be on a case-by-case basis. I would say, like, use your judgment. This is my opinion on how to fill out this one. Again, it would depend on the situation. And I'm sorry, I wish I had like a more definitive answer, but does that help at all?
I'm going to be honest, no.
Okay. Does this happen a lot? Are you getting a lot of failures on this one?
No, we don't have a lot of fallouts on this one, but the last section regarding patient contact information, if they're coming from a nursing home, their contact info is the nursing home. Their address is listed as the nursing home address, their phone number is listed as the nursing home phone number. They don't have separate contact info.
Okay, the issue that I think we have around that is, what if, you know, that the family then, let's say family or a significant other, whatever, they're not being notified that anything's being done with this patient in the facility. That one we've got to be strict on. I don't believe that the information that the contact being the nursing home, I don't think that's enough. I will do this. I will check again with the person. We work with the University of Minnesota Rural Health Research Center on these, and I will bring those concerns to her and talk about those and see if she feels that maybe we could answer this one different. But for now, I would say that would not be enough information. And if I find out different, I will get that back to Jill and let you guys know.
Okay, thank you.
And so I guess the way things are stated right now, I'm going to have to say for insurance information as well, that should be there unless the patient can't answer or refuses to answer. And I will run that by her as well. I will say, I certainly understand about that these aren't so easy to always get this information, and we are working on trying to update the measures. These measures are NQF endorsed, so they aren't measures that we can just change. But we have looked at and heard all of the, you know, the issues that you guys have around these, and we are hoping to make some changes to some of these measures and really just get to the heart of what happened while that patient was in there. And I think I may be taking too much time, so I'll like scroll by some of these. Now you're getting to vitals. I think they speak for themselves. I don't know that there's anything to say. We need to know that these were documented. It was documented that they were sent to the facility. We're not saying here that they need to have been done. This is that if they were done, was there documentation that they were sent. Blood pressure, unless anybody has a question about a specific one, let me know. Again, this isn't to say whether these should or should not be done. It's just that if they were done, were they sent?
This is Marianne Bloomer. I'm questioning on the sense. What if they're going to a facility that's within the, like if we transfer from a hub to our main, it's in our EPIC system. Is that considered sent?
Not automatically, because we have found that everybody has their EHR a little bit different. And we've also found that some sites don't update their systems right away. So even though you're putting that in, it might not be available to the receiving facility within that 60 minutes. So that's what you're going to have to determine.
Okay, but if it's like for us from going to Bloomer to Eau Claire, it's kind of one system. So it's not having to even be sent. They can see it.
Okay, and as long as you know that the minute you're putting it in, they're being able to see it. Because again, what we just kind of thought is that, oh, you've got a shared EHR with that facility. But then we were told some places don't update their information and share it right away. So if you know that sent to you would mean that as soon as that information is in it's been placed in your system, that they can see it in their system.
Yep,
Then,
that's good enough.
Yes, because then that would meet the 60 minutes guideline.
Okay. And that is the case for us transferring to like Bloomer to Eau Claire, but not Bloomer to a different hospital in Eau Claire that's not a Mayo facility. Okay, thank you.
Okay. Okay, neuro assessment right now, again, it's only required if the patient has altered consciousness, possible brain and head injury, trauma, a seizure, a stroke, or a TIA. If the patient doesn't have any of those conditions, you could put an NA for that. So only required for some of those conditions, the neurotype conditions. Meds, I think, are pretty self-explanatory. Meds that were administered in the ED. Okay, thing you have to look at, if no meds were given during the ED visit, there needs to be documentation that states there were no meds given to select yes. Just because you have an MAR that's blank isn't good enough in this instance. It needs to state that no meds were given. Allergies or reactions, okay, you don't have to have, it doesn't have to have the reaction to the allergy. We've had people ask that. So if it's worded as allergies, if it's worded as reactions, if both are there, that's fine. But we need to know that that was sent. If the documentation says allergies are unknown, you can say yes, because that is documentation of what that allergies were. There was an assessment. Or that somebody, it's unknown, but you did check to know, or you asked to know it was unknown. Does that make sense? Because a lot of times you'll see unknown, that would be a yes. Home medications, again, what was the patient on? If the patient is not on any home medications, that would be a yes. There's documentation that they're not on any home medications. History and physical or ED provider note. This is your provider's note. Maybe you don't call it a history and physical when it's in the ED. Initially, we never meant it to have to totally be called in history and physical, but we found out people weren't looking at this note because they thought it wasn't titled history and physical. So the provider note from your ED, your physician's assistant, whatever that note is called, okay? It's more important about what it must include. It must minimally include history of the current ED episode, a focused physical exam, exam on around why that patient is coming in. Any relevant chronic conditions. If the person has asthma, that should be documented. If they have COPD. Chronic conditions may be excluded if the patient is neurologically altered and you can't get a history from them. Reason for transfer plan of care, I think this is pretty self-explanatory, and a lot of times it's often on your EMTALA form if the patient is going to acute care. But why is that patient going back to going to where they are, or what's the plan of care now that they're going back to the nursing home? Nursing notes. again, whatever kind of, an assessment, if they have intervention, however they're worded, the nursing documentation from that visit. Sensory status, it doesn't say this has to be done by the physician. It's just really asking for some kind of documentation on being assessed for some of these senses. Mental, speech, hearing, vision. Okay, oftentimes you'll see ENT is within normal limits. That would be an assessment of speech and hearing. The patient is oriented or they're not oriented. That's an assessment of mental, facilities. If they have tingling or numbness. Nurse's notes, even if you see something about wearing glasses or has a hearing aid, that was deemed acceptable for this. So at least one of the following. It doesn't have to have all. If the patient had a catheter or an IV, and NA if there wasn't any catheter placed during this day. Immobilizations, if there was one done, that information should be sent. But if there wasn't, then that's an NA. We're talking about like if there was a backboard, if the person was given a cast, if they had a neck brace, any other braces. Respiratory support, NA if there wasn't any provided. What we're looking for is if they did any intubations, were they given oxygen, were they put on ventilator support, any kind of bronchial drainage. That's kind of what we're looking for here. Oral restrictions, if there were some placed. If not, then it's NA. By oral restrictions here, they mean, was there any information that the person was NPO? For some reason, were they just going to be on clear liquids or a soft diet, or if it mentions anything about a low sodium diet. If any of that is mentioned, that would documentation needs to be sent. Test procedures performed. Okay, so needs to be documentation that any tests or procedures done in the ED were sent to the receiving facility. Okay, if no tests or procedures were done, then you can select NA. So any lab work, any x-rays, any cultures. Okay, then we have this one, test and procedure results, because oftentimes maybe your lab culture isn't back yet, there's no lab result. Maybe you're doing some test that isn't, by the time the patient's left. So this one would be, if the results were not ready when the patient left, there needs to be documentation on how that information is going to get to the facility. So it says here, if facilities share medical records, then test and procedure results are considered sent. So for the person who was asking me before, they would just be able to see what those results were by pulling up the record, because you share that record. So anybody with a shared type of a record, that information would be considered sent. But if you don't share a record, then there needs to be some kind of documentation in your chart saying how that information is going to get to the facility. If there's no plan to communicate results, then that would be a no. And those are the data elements. Any other questions? And then what I want to get back, what I'm going to check on is the question that someone had about the, I'll check on two things. One was about the contact. I'll check to make sure about the contact to see if it is or if it would be acceptable if it was just the facility. And I'll check about the insurance to see if, about asking for that. Did anybody have anything else they wanted me to check on? Or any questions?
Robin, this is Jessica from Waupun and Ripon. I'm wondering if you see in a chart that a nurse has documented that they called SBAR report. What would you count as elements that would be done or communicated as part of SBAR?
If that's all I saw, okay, and I couldn't go back to anything that would say S is this and B is that and A is that. I couldn't say for sure what that contained, so that would mean nothing to me. I would say no.
Okay. Thank you.
This is Sue Coates. I would disagree with that because being a nurse, I would know exactly what the S-bar was.
And that's great, but we don't always have nurses that are doing the abstraction.
Usually they'll have, if your unit has an S-bar, like say your ED runs with an S-bar, you can get that information from them, exactly what's on an S-bar, what they've established as their S-bar.
I'm not saying that you're wrong. I'm just saying, I always want to say, if anybody could come into your facility and look at documentation and not have to ask anybody, what does this mean, what does that mean, then it would be acceptable. But I don't know just S-bar. If all I saw was S-bar was sent, I think right now I would have to say no, but I will sure check on that.
So Robin, this is Jill. So if, say, Ripon or Waupun develops a process that they have in place, so anybody that's doing that chart abstraction, they know what the S-bar elements are, similar to what Sue mentioned. If they build that into their abstraction process in sort of their work instructions, could that count?
I would say it can't be, it's about documentation. It's all about documentation. And because you know a process, again, if I came in to abstract that chart, I don't know your process. And so that's not going to work. It's got to be documentation in your chart. If you made a copy of your chart for me, if you made a copy of that whole ER visit, back in the old, made a paper copy for me, and I was re-abstracting that, would I be able to answer the questions with the documentation that's there?
If they had a formal S-bar tool that they developed, like, that's what the nurse used, it was laminated and on the desk, and they used that format every single time they called, and we could say, when you look at the chart, yes, we have a very detailed outline process for what is included in S-bar. So that again, when I'm abstracting, know what that means.
If I couldn't look at the chart, if you think about this, if you mailed your chart to me, would I be able to answer those questions without having anything other than the record?
Okay, so it has to be obvious to an outsider.
Pardon?
It would have to be something where it would be obvious to an outsider from our facility that they would be able to interpret it exactly the same way.
Yes.
Okay. Thank you.
Mm-hmm. Anything else? Okay, I think I'm done then, Jill.
All right. Robin, do you want to stop sharing your screen? Let me see if I can. Yeah, I don't.
Go ahead.
All right. So let me find my slides. Okay. And I apologize. Let me get to where I need to go with this. All right. So looking at the clock, we've got about 10 minutes, and I know I still have a fair number of slides to try to roll through for all of you.
You should have just stopped.
No, it's okay. It's okay, because I think this is helpful to walk through. And what I want all of you to be thinking about is, as we move forward, sort of those data components, what I want you to be thinking about is, are there specific data elements that you can go back and sort of identify where you know the breakdown in that process is occurring? So really quick, all of you, like I said, have been invited sort of to the Outlook invitations. This was just a reminder of when those calls are. Our coach calls then are usually going to be about 2 weeks after the actual webinar format. And they're, again, held on a Friday. the time shifts from 12 to 1 to 1:30 to 2:30. We may or may not take all of that time for that call, but it's really an opportunity for all of you to just sort of say, here's where we're at. It's really a check-in. Again, I will be tracking as part of our feedback to the Office of Rural Health how many hospitals are actually able to participate in that coach calls. So again, really, I just wanted to share with all of you just sort of that data element. So around that administrative communication, again, this is one of the identified areas of focus based on your GAP survey. I just wanted to share with you sort of how we're tracking as a state compared to nationally on this. Again, those numbers are sitting high, but I also want you to look specifically to, as Robin spoke to, not just focus on that measure and that metric. It's really looking at the data elements and really identifying where those gaps are to that specific element. EDTC2, that patient information, again, this was not an area that you said we really need help on this. Again, here's how we're looking in terms of from a state perspective and as a national, again, sitting in that 90%. The vital signs measure, you'll notice that this metric is one of the areas that you've identified in terms of that narrowed focus based on your gap. And again, here's the state and the national, again, in the 90% area. That medication information, I know that some of that was sort of concerns as you were filling out your gap and sort of that complete medication component. Here's how we're tracking for the state and nationally. Again, you're going to see those still are sitting in the 90%. Practitioner information, again, an area of focus, again, in the 90s, is state-wise and nationally. So I would encourage you to look at sort of your specific data compared to these components. If you also want me to provide you sort of a data set back to all of you so that you can actually track yours hospital specific, I can also do that as well. The nurse information, again, this was an area of focus based on what I saw through your feedback to us when you filled out that survey. Again, you're going to see us sitting a little bit higher than from a national perspective on this information. Again, both are still sitting above that 90%. That EDTC, that procedures and tests, so either taking the test or sharing those results, didn't see that as an area of concern for your organizations as we go through. And again, these are sitting, as you see, nationally and statewide in that higher 90% mark. So as just a reminder, this is sort of where I'm sort of identifying areas to focus on specifically to sort of the feedback that you have. What I did with all of your results then is really to identify, here's the measure, here's the strategies used, and here's sort of the barriers we've encountered and addressed. What I want to ask all of you is, would it be helpful for you to see sort of a summary of all these gaps? Now, it's sort of a breakdown of your feedback, but I wasn't sure how helpful it would be for all of you to see sort of the summary of that feedback. Is that something you would like me to share with all of you? All right, so I'm hearing no, meaning that isn't something necessarily that you want to hear back. I think what you're going to hear from, especially on our coach calls, is really that ability to say, specific to an element, here's where we're hung up. And my hope is that others on the line will say, either they're also struggling with that same measure, or they have an idea for you to use on how they identified on how they would move forward with that. These are really in terms of sort of getting in the way of that metric compliance. I know that it's really that understanding and that buy-in from staff. I think that's the other component that I want to focus on, especially as we look at kind of moving forward, that buy-in from the staff. I think part of that is around sort of those small tests of change that we're talking about it. I think that struggle with everybody is making sure that you have enough time. How do you fit enough time in the day? And so that's really looking at your processes that you have in place. Are there ways that you can automate your process? Are there ways that you can streamline your data collection tool, your transfer forms? Is there a way to share your transfer forms between even all of you that are participating on this? And really kind of that knowledge on what to document in the metric. That's really why we had Robin on today, kind of going through those specific data elements. And then it really is specific to, I know that observation bed And the hope was that, you know, they would review, these measures would be reviewed, and that would eventually come off. That may be in for the future, as Robin mentioned, as sort of NQF reviews this, but right now those measures are in. So we have to find a way to sort of identify how best to collect that information. Again, it's really about how do you standardize your processes and making sure that you're, you know, regularly auditing that component just to see, tracking that data, looking at it in terms of those elements. And then how do you develop a sustainability? So the idea is, I always equate it to, what if you win the lottery? And someone else steps in your shoes. There was a good question when we talked about sort of that S-bar and sort of that discussion around, from a nursing perspective, we'd know what that S-bar meant. And so internally we'd know that, but I thought it was an interesting point that Robin made. But if I was an outside person coming in to look at your medical record, would I be able to understand what that process is? So it's how you develop that internally. And again, really just a highlight to that specification. When we talk about kind of that improvement piece, and I know we've got about 3 minutes, so I'm probably going to go through these a little bit quicker. But in terms of that small tested change, what I really wanted to highlight for you is really to identify specific to that measure and that data element that you want to look at. What do you want to do? So I want to be able to improve this specific data element by, you know, we want to get 100% compliance by June. We want to be able to do that. And the way we're going to do that is we're going to measure that. We're going to track that information, which is how we're collecting that data now. That's how you're going to be able to see it. The change ideas are the things that you're going to put in place, or the ideas that you're going to test to identify how you're going to improve that specific data element. How you're going to do that is you're going to do those small tests of change. So it's really about each of those change ideas. You should be able to do one small test of change. And so when we talk about that, I want you to look back at your data and look at it a little different. Other than just from a metric perspective, I want you to drill down to identify, what data element do we see where we have an opportunity? What do we want to focus on? And I want you to be thinking about that, to bring that to our coach call in 2 weeks. And again, understanding what is our current process. Internally, do we already know what barriers we have in place? Some of you have already identified that. So even if you take from what you shared on your gap analysis, it may be part of that metric itself, but that component is its own piece. And so that's really where where I'm stressing is, make sure that you're documenting these processes. And then when we talk about that plan, do, study, act, that planning piece isn't meant for you to do this as we're going to take 2 months to figure out what our plan is. We want you to be proactive and do this real time. So really that doing is really testing that small test of change, really engaging the right people in that component. And we can also talk a little bit more on our coach call around that kind of small test of change. But it really is, when you're actually doing this, it's really filling out the form and actually being able to document what you did, what you tested, what worked, what didn't. How do we move forward? How do we test with more people? Because what you don't want to do is, I'm going to design a new process and then we're just going to roll it out without testing it, especially with staff. And what we're talking about is have one person try this on one patient. Have two people try this on 2 patients. Then as you sort of go different times of the day, really to see, is this process really working for us? And again, it's more of that real-time approach. Again, looking at, we want to use those failures as opportunities to understand how we improve our system. Again, I think this is probably familiar with all of you, but really, this is really just to encourage you when you're running up to that staff going, why do we have to do this? I think when you start to design sort of your small test of change, again, one person, one patient, one shift, one time, really making sure that you're documenting, engaging that frontline staff, especially if they're being the testers. And I think that's one way to get their buy-in, is really for them to understand why we're collecting this data and what do you use this data for? How often do they know that what this information is used for and why it's important to collect it? So that can be all part of your kind of testing piece. There is a PDSA worksheet that we actually provided within your Outlook invite today. Within that document, it's actually a writable PDF. So what I want to have you do for our coach call in 2 weeks is identify what that data element is. if you can do it as much as that to identify that data element, we can walk through the rest of this because I know we're right up on that 1 o'clock time frame and I want to be cognizant of your time. So again, identify your initial focus, that data element that you want to do. If you can, within the next 2 weeks, start to fill out that PDSA worksheet, great. If you can't, at least have your idea of what you want to do, bring that worksheet for our dial-in. Call on February 15th, because then on our March webinar, I actually want to have all of you share what component you're going to work on. We're going to delve into a little bit more around that action planning, but I also want it to be sort of that best practice sharing between all of you and really utilizing sort of that feedback that we have that you gave within that your gap assessment to really tease out some of that information as well. So I know that was really long-winded. So I appreciate you being, we went a few minutes over, but any last-minute questions before we sort of hang up for today? I don't see anything within the chat box. So just a reminder, on February 15th, if your team is able to dial in to that mentor coach call, where Sue is actually going to sort of be, I'll facilitate that conversation and Sue will be your point person on that call. And then March 8th, we'll come back with our second webinar in our series where we're going to kind of look at that action planning. We'll take more of the information sort of that you provided basically from your coach call as well, and I'll use that to develop the slide deck and kind of form our conversation for that March 8th webinar. All right, so at this time, I just want to thank everybody for being on the call, and I hope you have a wonderful rest of your day, and I hope that you're enjoying this warm-up that we're having, especially in our state. Thanks, everybody.
Thank you.
Thank you.
Thank you.